Good morning, everybody, and thank you for attending my short presentation on abdominal decompression as a major contributor to amniotic drainage-induced circulatory dysfunction following intrauterine interventions for twin-to-twin transfusion syndrome. Twin-to-twin transfusion syndrome complicates around 10% of all monochorionic diamniotic twin pregnancies. Induced by unbalanced inter-twin blood flow through vascular anastomosis on the placental surface, the condition leads to volume depletion in the donor twin and simultaneous volume overload in the recipient twin. Left untreated, the process is mostly progredient, and in these cases fetal outcome is usually unfavorable. Fetoscopic laser ablation of placental anastomosis is currently the best treatment available for TTDS, yielding double survival rates of more than 60% in large recent series. FLA is usually completed by amniotic drainage of the recipient's excess fluid between 1,000 to 4,000 milliliters to achieve normal amniotic fluid levels. In contrast to the high number of scientific reports on fetal outcome and treatment options, data on maternal hemodynamic changes or adverse side effects following FLA procedures are scarce. Clinical signs suggestive of maternal hemodilution were described in cases of mid-trimester TTDS managed by FLA and subsequent amniotic drainage, providing first evidence that such interventions pose significant impact on the maternal compartment. A variety of observations, including maternal hemodynamic adaptations, decrease of intrauterine pressure, and increase of placental volume, have been described following high-volume amniotic drainage. The observed hemodynamic characteristics may be severe and are then similar to the so-called Ballantine syndrome or mirror syndrome. However, the mechanisms leading to these complications are still not comprehensively understood. In a recently published work, we could demonstrate that maternal hemodilution is not only the exception but a frequent observation after high-volume amniotic drainage. As you can see on the figure, maternal hematocrit, hemoglobin, and serum albumin dropped significantly from preoperative measurements to postoperative measurements suggestive for maternal hemodilution. Furthermore, we were able to demonstrate a significant relationship between the amount of amniotic fluid drained and maternal hemodilutional effects. It became apparent that the ultrasound-guided amniotic drainage was responsible for those effects and not FLA. Therefore, we hypothesized that abdominal decompression due to high-volume amniotic drainage might be, at least partly, responsible for maternal hemodilution effects and circulatory disturbances after FLA. We performed a single-center pilot study between March 2017 and May 2019. We included monochorionic diamniotic twin pregnancies complicated by twin-to-twin transfusion syndrome between 16 and 26 weeks of gestation. Intra-abdominal pressure monitoring was performed according to international standards via a Foley catheter placed inside the urinary bladder. After emptying of the bladder, 50 milliliters of sterile saline solution was inserted and the catheter was linked to a digital pressure transducer. We measured intra-abdominal pressure every 200 milliliters and started before amniotic drainage and performed the last measurements after the drainage was finished. We recorded under stop flow and no touch technique, and measurements during contractions were discarded. Maternal serum albumin and hematocrit were recorded before and 24 hours after intervention. So, in this study, we showed that maternal hematocrit dropped from 33.3 before to 28.1% postoperative, and serum albumin decreased from 37.9 to 30.1 gram per liter post-operative measurements. Based on the calculations by Schneditz and colleagues, we could demonstrate a relative expansion of blood volume by 18% and the relative expansion of plasma volume by 24%, as expected for hemodilution in absence of true hemorrhage. Corresponding to those changes, the intra-abdominal pressure significantly decreased from 17.7 to 9.7 mm mercury. Furthermore, we could objectify a dose-dependent effect of amniotic drainage volume on the intra-abdominal pressure in a linear regression model. So, in conclusion, we may state that ultrasound-guided fetoscopic interventions with subsequent amniotic drainage show significant maternal side effects, and high-volume amniotic drainage is associated with a significant decrease of intra-abdominal pressure and maternal hemodilution. Thus, we would like to introduce the term of amniotic drainage-induced circulatory dysfunction, AICD, to describe pathophysiological circumstances after and during high-volume amniotic drainage. Thank you so much for your attention and have a good day.
Hello, my name is Tobias Tolsen. I'm a specialty registrar in otolaryngology head and neck surgery in Copenhagen, Denmark. I would like to present a study with the title A Randomized Multicenter Clinical Trial of Transoral Ultrasound versus Standard of Care in the Diagnosis of Peritonsillar Abscess. Peritonsillar abscess is the most common deep neck infection, and it can be difficult to see the difference between an deep neck infection and an abscess on the clinical examination only. The treatment is either needle aspiration or quinsy tonsillectomy. The preferred treatment in Denmark is currently needle aspiration, but due to the difficult diagnostic workup, a lot of needle aspiration attempts are unsuccessful. Instead, transoral ultrasound can be used as a point-of-care imaging to improve the diagnostic accuracy. Previous studies have described a technique using an endocavity transducer for the diagnostic workup. However, the endocavity transducer is quite big and it's not possible to do an ultrasound-guided needle aspiration. Instead, I've been working on a technique using a smaller transducer, seen here as a neurosurgical transducer, and a flexible hockey stick from BK Ultrasound. Looking at the ultrasound image, you can see here an inflamed tonsil without an abscess, and on this image you can see an abscess cavity before and here after drainage with a needle aspiration. With the use of the neurosurgical transducer, you can attach a needle guide so you can reach the abscess cavity and do a drainage very precisely, which I have described in a previous paper. Here you can see a patient with a peritonsillar abscess, and I put inside the neurosurgical transducer with a needle guide, and here you can see the line coming here and the needle going into the abscess cavity, seen here, and the nurse are asked to do an aspiration of the abscess. If the patient have troubles with opening the mouth, it may not be room enough to put on the needle guide, and instead you can use a freehand technique where you put the ultrasound transducer on the peritonsillar swelling, and you can guide the needle inside to the abscess cavity and start the drainage. So the research question for this study was if we could use transoral ultrasound to improve the diagnostic accuracy and decrease the number of needle aspiration attempts performed. So we performed a randomized controlled clinical trial at 2 different centers in Denmark, the Department of Otolaryngology and Head and Neck Surgery at Rigshospitalet Copenhagen, and the Department of Otolaryngology Head and Neck Surgery at Odense University Hospital at Fyn. Patients suspected with peritonsillar abscess above 18 years were asked to participate in the study and were randomized to a clinical examination or transoral ultrasound. Before we started the study, we trained all the otolaryngology residents on call who would see the patients with a peritonsillar abscess, and for the purpose I developed a phantom with some balloons inside, and all the residents performed an ultrasound guided aspiration of the balloons, both with the needle guide on and with the freehand technique. Further, they also received a 30 minutes lecture about transoral ultrasound and different cases. The patient were either randomized to the ultrasound or the control group. If there was an abscess suspected in the ultrasound group, there were performed a needle aspiration either with the needle guide or with the freehand technique. If no abscess were suspected, the patient were treated with antibiotics and follow up in the outpatient clinic. In the control group, the same treatment were given to the patients without suspect abscess, and if there was a suspected abscess, they will also have a needle aspiration performed. However, it would be without ultrasound. So in the study, we enrolled 96 patients, and 47 were allocated to the intervention group and 49 to the control group. And 46% of the patients in the intervention group were treated with needle aspiration compared to 97% in the control group. And we found a significant decrease in the number of needle aspiration performed at the first visit in the outpatient clinic, and also a significant decrease in the total number of needle aspiration performed after ending the treatment and follow-up in the outpatient clinic. Looking at the diagnostic accuracy, we found an increase from 33% in the control group to 81% in the intervention group. However, doing logistic regression, we didn't find power enough to a significant increase. Looking at the secondary outcomes, we found that there were no difference in the number of visits in the outpatient clinic or the number of sick days between the intervention and control group. However, we found that trend towards more of the patients in the intervention group were admitted to the hospital, which may be explained that more patients in the intervention group had quinchy tonsillectomies performed compared to the control group. Looking at the needle aspiration in the intervention group, we found that half of the needle aspiration were performed ultrasound guided. There were 28 different physicians treating the patients in the study, and 33% of the physicians answered that transoral ultrasound did improve their diagnostic workup. A limitation to this study is that some of the physicians used quinchy tonsillectomy instead of needle aspiration for treatment of peritonsillar abscess, and because of they saw the abscess cavity on ultrasound, they didn't perform the needle aspiration. Further, we had 28 different residents performing the procedure unsupervised because the patients are coming on call. So many of the residents didn't get a lot of experience with the ultrasound before we ended the study. Another limitation may be due to the technical issues with the ultrasound guided aspiration, because they used a longer needle with attachment to a syringe. Some of the cases found it difficult to aspirate all the pus in the abscess due to a less pressure when using the syringe. There's one other randomized controlled trial comparing ultrasound to clinical examination of patients suspected for peritonsillar abscess, and they found a 100% diagnostic accuracy of using ultrasound. However, they only included 28 patients, while we included 95 patients, and they had a single center study while we have a multicenter study. Further, they had some few experienced attending emergency physicians to supervise the residents on call for each procedure, which would not be the clinical situation in Denmark. So the diagnostic accuracy we found in our study was a bit lower than this study, but we find it more realistic to a clinical setting with a lot of different physicians taking the on-call calls. So with this study, we can conclude that transoral ultrasound can reduce the number of unnecessary needle aspiration attempts in patients suspected of having a peritonsillar abscess. However, more training may be needed to decrease the number of false negative and to perform ultrasound-guided aspirations technique of the physicians on call. Thank you very much for your attention.